I want to introduce the keynote speaker for the session, Rebecca Kahn.
So scenario models are useful for thinking through hypotheticals. What if a new variant emerges over the next few months? What if the vaccines wane faster than we think they might? What if we introduce new boosters? What if we implement mask mandates or we lift mask mandates? But scenario modeling is also really hard to do. So in this talk, I hope to highlight some of the lessons learned over the past few years and identify some ideas for the path forward and how we can make scenario modeling most useful. And I think those ideas largely fall into the categories of plans, parameters, and policy. So to highlight some of the challenges with scenario modeling, I want to use an example from one of the first scenario models that I built during COVID. So in January 2020, some colleagues from the New York City Department of Health reached out and said, we haven't identified a case yet, but what could this look like for us over the next few months? So I built a simple model and allowed users to vary different parameters because there was so much uncertainty at this time. So they could vary the number of introductions that had occurred at this point, the reproductive number, how much transmission was occurring pre-symptomatically. And I think this was useful for trying to identify which parameters were most important for affecting the dynamics of the epidemic, and also to give a sense of the range of possibilities of what this could look like. And I do think that it was useful in helping to raise the alarm that this could potentially get really bad, and did lead to some action from the government. However, with all of this uncertainty and all of these different parameters, in this model I had 4,000 different scenarios. And of course, New York City wanted one. So I've started thinking a lot since then about how we can help to narrow the uncertainty when developing scenario models. And the first piece I'll talk about is plans and parameters. So a lot of the challenges with building models is needing data to go into these models. And while we can't anticipate everything in advance, there's a lot we can do to plan studies, pre-position them, prepare protocols, and think through what we might need so that it can be quickly adapted to the question of the day. And I think the data that we need from these studies largely falls into two big categories. The first one I'll focus on is having data on incidence and cumulative incidence, because to build a model thinking about where we're going, it's important to understand where we've been, how many people have been infected so far, and where we are right now. Is the epidemic growing? Is it shrinking? Has it plateaued? And of course, daily reported case counts is one source for this input, but we all know that there are challenges with this. There are changes in reporting practices over time. There's changing in who gets tested. There's changing in availability of testing. More recently, home testing has made this even more complicated to interpret. So this is not necessarily the gold standard data source for thinking through incidence and cumulative incidence in our models. And instead, another option is to have representative population level studies that give us a better sense of what's been going on in our population. And I think over the course of the COVID-19 pandemic, the UK has done a really nice job with this and setting up studies that give a more population level view. So I've highlighted 3 on the screen here. 2 of them, REACT and ONS, are random samples of the population looking for people who are actively infected at the moment. And they've done this periodically over time. The third study is the SIREN study in healthcare workers that looked at antibody testing and seroprevalence to see how the proportion of people that have evidence of any infection has changed over time. So I think this is an example of a way in which you can get more representative information about what's going on in your population to set up a model. In the US, I think there's some examples of how this has been done in healthcare settings. So the paper on the left is from a group in Indiana that showed how routine hospital testing performed better at predicting clinical burden than the state's case counts. The right is showing a figure from a paper that used labor and delivery testing in New York as a proxy for prevalence. And they showed how changes in mobility data at the beginning of the pandemic correlated with this prevalence. So in boroughs where mobility declined from lockdowns, the prevalence was lower than in places where mobility stayed the same or was higher. And then I think many of us have seen the graphs of wastewater data that correlate heavily with case counts. And I think there's a lot of exciting opportunities for research to understand what wastewater can tell us. But it is also a more representative sample and does not rely on people's behavior as much as an input into our models. So that's thinking about data on incidence and cumulative incidence to set up our models for where we've been and where we are. Of course, to think about where we're going, we need to understand the parameters as well. So I'm going to highlight 6 example parameters and thinking through how we can be best prepared to get these data sources and build our models. So of course, when we're building scenario models, we need to understand viral dynamics and how transmission is occurring. So this is a paper from a study among basketball players in the NBA, where there was repeated testing done over time. And I think one nice thing this study highlights is that for some parameters, you don't need population-wide studies. You can have a smaller group of people where you have a lot of detailed information, and having that detail can be more important than having a large study. So in this study, they were able to look at the viral kinetics among vaccinated and unvaccinated individuals. They were able to look across different variants. And this is really important for building models and thinking through policies such as isolation and quarantine guidance and how we might expect different tests to perform. Another parameter that's important for parameterizing models is severity. So back in November and December, when Omicron was first emerging, there was a lot of data coming out of South Africa in particular showing that Omicron was more transmissible, that the vaccines didn't work as well. But a key question was, how severe is this? And so a group of us worked with Kaiser Permanente in Southern California to do a study comparing the severity of people who were infected with Omicron compared to Delta. And what we found is that for all the outcomes listed on the screen, Omicron was less severe compared to Delta. Of course, with the increase in transmission, there was huge burden on the hospital system as well. But this was important to understand among people who were infected what the relative severity was. Now this study worked well because we had a data source with longitudinal information on the population, we had demographic and clinical characteristics, and they were also using a PCR test that allowed us to distinguish Omicron versus Delta. But this is not always the case, and we might not always have those data sources ready. So it's important to think through how we can best prepare to do these studies in advance. Now, setting up studies and designing protocols is important, but it's not the only thing that we need to do, because there's a lot of potential for bias in estimating parameters from these studies. So this is a paper where a group of us looked at several different potential sources of bias in studies of SARS-CoV-2 and COVID transmission. So I'll highlight one example here, focused on the parameter of secondary attack rate. So secondary attack rate is the proportion of someone's contacts who end up getting infected. So here we have an example with a household of 7 members. And the red person in the middle is the index case, so they're the first case in the household. And they go on to infect 4 others, those that are highlighted in red. So the true secondary attack rate is 4 out of 6. If for some reason we miss the index case and don't identify them as someone who is infected, we can get a biased SAR. So the yellow individual here was falsely identified in this example as the index case, and we get a secondary attack rate of 3 out of 6, biased down. So in this paper, we highlight different examples of how bias can arise and also recommend ways to design studies to reduce the bias. So in this example, having rigorous follow-up, potentially with sequencing to try to understand direction of transmission can help with this. It's not necessarily logistically feasible, but when possible, doing prospective designs can be helpful. Standardizing protocols and definitions for who counts as a contact, and just following people up long enough to make sure we capture all infections. Now, a lot of my research has focused on using simulation to try to understand different sources of bias and how to mitigate it. So simulations are useful because you can try to capture complex transmission dynamics and to really dig into what's driving those and where bias can arise, and to test out ways to alleviate that bias, either through study design or analysis methods. And it's helpful because you can do this in advance and you don't have to wait for the study to happen before you can figure some of these things out. So the next few examples I'll talk through are using this approach to figure out how to estimate parameters in an unbiased way through simulation. So the first parameter I'll use as an example is seroprotection. So it's important to know if people have been infected in the past, does that change their risk of getting infected in the future? And often this is measured through antibody testing as a proxy for past infection. Of course, there are many potential sources of bias and confounding in this. For example, someone who has a high-risk job is more likely to get infected in the past and more likely to be infected in the future. In this study, we showed how even geographic structure and epidemic dynamics can cause this same source of bias. So in this paper, we developed a susceptible, exposed, infectious, susceptible model in a network framework. And we varied the amount at which people were susceptible after their prior infection. And then we simulated enrolling them into a seroprotection study. So we had the outbreak begin, we enrolled people into the study, and then we followed them up over a period of time. And we looked at what would happen if you enrolled everyone in this study on the same day, so here day 100, versus if we enrolled people on different days. So in this example, days 50, 100, and 150. And we also looked at what would happen if you did a matched design, where for every seropositive individual enrolled on day 50, you enrolled a seronegative individual. So we assessed the serostatus on the day of enrollment. We followed people up over time to see who got reinfected, and we used a Cox proportional hazards model to calculate seroprotection. So in this example, I'll show you for the results. This is a simulation in which there's no seroprotection. So this is a simulation under the null in which the hazard ratio is 1. So in this first example, we looked at a network of individuals grouped into just one community, and we enrolled everyone on the same day. And as expected, we did not see any bias because everyone's from the same community and enrolled on the same day. So our estimates are following on the vertical line of 1. In this next row, we looked at enrolling individuals on different days throughout the epidemic. And here we see that our unstratified analysis is biased upwards, making prior infection look harmful when in fact we know it's not. And the reason this occurs is because those individuals who are enrolled earlier on in the study are less likely to be seropositive because the outbreak has just started, and they have a lower risk of infection over the course of the rest of the study. So the gray bars here are showing the average hazard of infection for people enrolled on different days. So people who are enrolled earlier are less likely to be seropositive, less likely to be infected. People who are enrolled later when the epidemic is at a higher rate are more likely to be seropositive and more likely to get infected again. But you can see here that stratifying by day of enrollment corrects this bias. In the third section here, we looked at if we matched people on day of enrollment, and here you can see that that also alleviates the bias. We then looked at what happened if people are grouped into 10 different communities as opposed to 1. And here, even if we're enrolling everyone on the same day, because the communities have different epidemic timings and the epidemic is introduced at different points, we get that same phenomenon where some communities are earlier on in their outbreaks than others. So we see that same upward bias that we saw when people were enrolled on different days. So again, stratifying or matching alleviates that bias. When we enroll people on different days from many different communities, we see an even stronger upward bias, but matching or stratifying alleviates that. So I won't go through some of the other examples, but just to summarize the findings from this paper, we found that you can have bias in studies of seroprotection if you have people from multiple communities that have different timings of epidemics, or if you're enrolling people on different days, but that this can be alleviated by matching or stratifying. We also found that if the communities are more clustered, so as opposed to everyone mixing with everyone in their community, you can also get this bias, but it's harder to control for because it's not necessarily a well-defined community that you can stratify on in your analysis. So there might be ways of matching on neighborhood or household for this, but it becomes a little more complicated. But I think in this study, what we found through simulation was that things like community or epidemic timing can cause bias, and it's important to think through the magnitude and direction of this bias when conducting studies like this. Next, I'll focus on a vaccine effectiveness parameter. So around a year ago, when we were working on this, a big question about SARS-CoV-2 vaccines was, does protection wane over time? But we know that studies of vaccine effectiveness over time are subject to bias from differential depletion of susceptibles. So over time, people who have been previously infected, who have some protection against reinfection, and who are more likely to be unvaccinated than vaccinated are included in your analysis. So more unvaccinated people at lower risk in your analysis makes the vaccine look less effective than it is. And this increases over time and leads to what's known as spurious waning. So in this study, we looked at simulating an outbreak with a vaccine study, and we looked at what would happen if we were able to identify people who had been previously infected and exclude them from the analysis. So in this, we simulated serologic testing to identify people with prior infection and exclude them. And what we found is that in scenarios where we have a high vaccine effectiveness, the bias from differential depletion of susceptibles is small. So at this time, we were starting to see reports of waning of some of the mRNA vaccine effectiveness. And what our simulation showed was that this was likely not completely due to bias, and there likely was true waning, which I think the results of the effectiveness of boosters have further confirmed. However, in simulations where we had a lower starting vaccine effectiveness, we found that spurious waning occurred, and a lot of the waning was actually due to bias. And it was important to exclude those with prior infection to correct for this bias. And then finally, we compared different mechanisms of action for vaccines, leaky versus all or nothing, and found that that did affect which analytical approach was more accurate. The final parameter that I'll talk about is vaccine efficacy against transmission. So the vaccine trials did not directly estimate this, but understanding how much the vaccine affects transmission is important for developing models of spread and thinking through the impact of a vaccine program. So vaccine efficacy against transmission is a function of three components: the vaccine's ability to reduce infection, to reduce your duration of infectiousness, and to reduce the amount you shed when you are infectious. So in this paper, we looked at a combination of the first two components of this, known as viral positivity. And we found that this formed a lower bound for VE against transmission. So looking at the data from the Moderna trial, using this approach, we estimated that one dose of a Moderna vaccine at this time provided at least 60% protection against transmission. However, what we also found in this study was that if you analyze people who get tested for different reasons, so some people get tested because they've been exposed, some people get tested because they have symptoms, and some people get tested periodically either for work or school or if they're part of a trial on a routine basis. If you analyze all of them together, you get an estimate that's not really interpretable because the estimates you're getting are functions of many different things. So it's important to analyze these separately. So I've talked a lot about thinking through how we can design studies to get parameters that can be input into models, whether that's for understanding incidence or cumulative incidence, or for getting specific parameters. But there's one additional component that I'd like to touch on for how we narrow the uncertainty in our scenario models, and that's policy. Because oftentimes the scenario models that we build are meant to inform decisions made by leaders in a response. And so while some policy decisions might look great in a model, if they're not feasible logistically or politically, then the model will not be as useful. So you'll hear a lot more about this in the next talk, but I want to highlight that the COVID-19 Scenario Modeling Hub, which is a collaboration between CDC and many different academic groups, where They develop a set of scenarios, and different groups submit models, and then an ensemble is produced. Has been really useful for thinking through different scenarios over the course of the COVID-19 pandemic. And what I like about this example from round 9 here is that they looked at 2 different axes of uncertainty. So they had a scenario in which there was a new variant and there wasn't a new variant, and that's less in our control. And then they had a scenario in which there was childhood vaccination versus no childhood vaccination, which is more in our control. And so I like how they have this kind of scientific axis of uncertainty and policy axis of uncertainty, because I think it's helpful for narrowing out the choices down. And then, as Katya mentioned, while I'm giving this talk in my role from Harvard, I'm also part of CDC's new Center for Forecasting and Outbreak Analytics, or CFA. And one of the things we hope to do within CFA is to really improve the relationship with decision makers and to really understand what they need from models and analytics, and really work to translate the results of models and analytics into a way that is useful to decision makers. So we're devoting about 1/3 of our resources to what we're calling Inform, or our communications arm, that really works to translate the results and to communicate them to decision makers, and also to develop the relationships to understand what they need and how our work can best support them to make decisions. So I'd like to end with this figure from a recent paper from Katya and others who are here that looks at the different changing epidemiologic questions over the different phases of the pandemic. So they look early on versus riding out the waves to vaccines and variants. And I think while for different pathogens and different variants, some of these questions will change, it's a really useful framework for thinking through how can scenario modeling help, and what are the key questions and areas of uncertainty that we can design studies for, and parameters that we need to figure out how to estimate in an unbiased way to help us improve our scenario models and to make them useful. So with that, I'd like to thank you all for listening, and we'll be happy to take any questions.
Hi, thank you for your talk. It's really informative. So just going back to one of the previous slides, you mentioned that you use case data to sort of model pandemic scenarios. I'm just wondering, sort of in the absence of population prevalence surveys such as the REACT-1, how would you take into account sort of spatial temporal heterogeneities in sampling or in case data? Like, for example, for the introduction of sort of mass testing or the removal of mass testing, etc. Thank you.
Yeah, thanks for that question. I think it's a really big challenge. I think, there is some research going on in figuring out, trying to understand behaviors and model home testing and how that can inform models. But of course, as you mentioned, that's going to be really heterogeneous across space and across time. So I don't have a good answer. I think case data are really challenging. I think hospitalization data and death data are more stable than case counts, and so there are approaches for using those instead of case data or in addition to case data. I think there's some behavioral surveys that can be done to try to capture some of these dynamics, but I think it's really hard, and that's why I think studies like REACT and others are really important for getting that data source.
Hi there, thanks so much. This hopefully is a quick question, but so a lot of the parameters that you shared and showed seem like they could expand to other planning for other pathogens as well. But I wonder if you could share some of your thoughts about how to think through what might be the best parameters to try to apply, especially as we start to think about, oh, well, this would be great for my bacteria over here or my completely other virus with different transmission. Thanks.
Yeah, that's a good question. I think there are a couple approaches. I think one way is to think about what decisions need to be made. So from CFA at least, a lot of what we're doing is thinking through what decisions need to be made, working backwards into what analytics or data can help inform that decision, and then what parameters are important for that. So I think thinking through for different pathogens what the decisions or policy choices might be can be a helpful way of thinking about that. I also think while the model that I did for New York, of course, had way too many scenarios, I think developing models like that and looking to see which parameters actually do matter and do make a difference in terms of the outcomes you're looking at can be helpful for targeting studies to say we really do need to figure out what this parameter is, whereas this one doesn't seem to make as much of a difference, so might not be as important to focus on.
Wondering whether you could elaborate a little bit on CDC's CFA that's kind of up and coming, and talk a little bit about what the vision is there for the interaction between policymakers and CDC, and then folks who are more like many of us, kind of in the academic community. And so, is the idea to bring in infectious disease modelers into kind of this center, or is there more for collaborative ties between the center and universities?
Yeah, so with CFA, we're divided into 3 main functions. So we call them predict, inform, and innovate. So predict is really our data analytics and modeling team, where that will be people in-house at CDC doing these models, whether it's scenario models or short-term forecasts or questions about testing or vaccine policy, things like that within CDC. And then there's the inform component, which I mentioned, which is the communications arm that's really working to translate those models and develop relationships with decision makers at all levels within the federal government and state and locals. And then we have an innovate arm where we're really hoping to advance research and development in the space, recognizing that we do need to get better at forecasting, at scenario modeling. And there's a lot of room for innovation, and especially within the innovate arm, that's where we hope to partner and are already partnering with different academic groups, with the private sector. So it's both. We hope to have a really strong in-house modeling and analytics team, but then also really work with academic groups as well.
So this is more focused on the policy side than the science side, but I'm curious how you keep from being super pessimistic, because you talk a lot about, we think about what decisions need to be made, and then we figure out the data, and then we come up with an answer, and then that doesn't actually get turned into policy, right? Like, we're all here wearing masks because we know that that is a smart policy, but nowhere else, mask mandates are done, And so, I hope you don't take this as an attack, because it's not at all, but how do you, it just feels like there's a contradiction between the CDC is coming up with this fancy new center to try and integrate data into policy, and we aren't even integrating the current data that we have into policy. So can you talk a little bit about that maybe? I know that's a really hard question, but that's I feel like that's what's on my mind right now, and I think that's probably on a lot of other people's minds too.
Yeah, no, I think that's a really good and really important question. I think part of it does come down to improving our communications. Uncertainty in modeling is a really important component, but it's also really challenging to communicate, what is uncertain, why it's uncertain, and to be okay with saying, we don't know this yet and we're trying to figure it out. And so I don't think it will fix everything, but I think working to improve our communications and to really understand what the questions are and to try to figure out how we communicate results in a way that is useful to decision makers and useful to the public is an important first step. I think having good data and modeling and analytics is only one piece of it, and that we need to work on the communications part as well. But it's a big challenge and a good question.
I just wanted to ask a question about how do you position yourself to be ready to answer that question of the day? So how do you build models that are both flexible enough and also complex enough to handle whatever policy questions and whatever epidemiological complexities you need to figure out as the situation evolves?
Yeah, it's also a really good question. I think a lot of what we've been doing at CFA so far has been heavily informed by COVID, and we are starting to think through, for other things, such as monkeypox, for example, what are the different questions? Some of the questions will be the same, and of course some questions will depend on the characteristics of the pathogen or where it is. So I think, trying to think systematically through, different characteristics of pathogens and outbreaks to figure out what we need in order to be prepared is important. of course, we can't anticipate everything in advance, but I think trying to think systematically through is important. And I think also, building a team where you have, consistent code or models that are flexible and easily adaptable, and being able to quickly onboard new people in an emergency response. You can't, again, prepare for everything in advance, but if you can have models that are easily adaptable, that's an important first step.
Thank you.
Hello, we have a question from online. How are social sciences being brought into this center?
Yeah, that's a really good question. I think, as we build out CFA, I think one of the areas in which we're really interested in is behavioral science, because I think we've seen that behavior is so important for understanding the dynamics of transmission, but also so hard to understand and actually incorporate into models. So that's an area that we're really interested in, and for our Innovate arm. And I think we're also, working with others at CDC and across the federal government to figure out, where we can partner with people to bring in that expertise that we won't have. We're hoping to be a little over 100 people, so of course we'll need to rely on partnerships with others as well.
Great, thank you. Thank you so much.